Good morning, respected seniors, my colleagues and juniors. I am going to present on the topic perioperative physiotherapy in cases of lung resection surgery. Lung cancer is the most common cause of cancer-related deaths worldwide. Surgery is critical in treating lung cancer and other thoracic pathologies. Surgical resection is gold standard for early stages of lung cancer and is most effective curative treatment for non-small cell lung cancer. It improves survival and improves the quality of life. Perioperative risk factors and treatment measures can result in nasal lung damage. Overall surgical mortality for pulmonary resection range is in a large series is from 2 to 4%. The estimated mortality increases with the size of resection, that is less than 1% for a waist resection of the lung, 2 to 3% for a lobectomy, and 6 to 8% for a pneumonectomy. Risk factors for postoperative complications include age, that is more than 65 years of age, chronic respiratory illness, history of smoking, low preoperative functional status, poor nutritional status, and extensive surgery, that is pneumonectomy. The common postoperative complications are atelectasis, pneumonia, bronchospasm, hypoxemia in respiratory system, arrhythmias, hypotension, myocardial ischemia and cardiovascular system, surgical complications like hemothorax, chylothorax, prolonged air leak and bronchopleural fistula, and other infections like wound infection, thromboembolism with prolonged ICU stay. The role of physiotherapy is to improve ventilation and oxygenation. It reduces postoperative complications, enhances airway clearance, strengthens respiratory and peripheral muscles, promotes early mobilization and recovery, and reduces morbidity, improves outcome, and shortens hospital stay. Preoperative preparation for reducing postoperative complication and easy rehabilitation, patient education is a must. The content of preoperative patient education includes patient self-preparation, introduction to relevant policies, postoperative bed arrangement, cooperation, symptom management, and individualized guidance. This encourages patients throughout the treatment, during surgery, and during post-rehabilitation stages. One of the key for preventing postoperative complication and successful surgery is smoking cessation. The relative risk of postoperative complication smoker is 1.4 to 4.3 times that of non-smokers. It is recommended to quit smoking and avoid alcohol consumption at least 4 weeks prior to the intervention. Preoperative pulmonary functions should be assessed. The PFT is done. PFT is usually affected by ventilation and airway obstruction. A value of predicted postoperative FEV1 of 40% is currently used to distinguish between normal and high risk in lung resection patients. The patients with low FEV1 are at higher risk of postoperative pulmonary complications. FEVR, PFR, that is peak expirative flow rate, it mainly reflects the strength of respiratory muscle and patency of airway. The PF is less than 320 liters per minute. The patient has trouble in expelling flames after surgery, which may result in infection. A predicted DLCO value of less than 30% is suggested to be a high risk, with maximal oxygen consumption, that is less than 15 ml per kg per minute, is associated with about 75% of postoperative morbidity rate. Cardiopulmonary exercise testing includes measurement of maximal oxygen consumption, that is peak. It is measured during incremental exercise on a treadmill and cycle, and peak VO2 less than 30% is kept in high risk for postoperative complications. This is a diagram which gives us idea about preoperative assessments and what surgical modalities should we opt for. At first, when a patient is indicated for surgery, we go for cardiac assessment. Once the patient is fit after cardiac assessment, pulmonary assessment is done. In pulmonary assessment, FEV1 and DLCO is checked. If both FEV1 and DLCO is more than 80%, the patient is fit for surgery and can go up to resection, up to pneumonectomy. If either FEV1 or DLCO is less than 80%, we go for peak oxygen consumption during exercise testing. If it is less than 35%, the patient is falls under high risk group. If it is 35 to 75%, the patient falls under intermediate risk group, and if it is less than 75%, the patient is under low risk and go up to resection up to pneumonectomy. After exercise testing, if the patient is under intermediate group, that is 35 to 75% of maximum oxygen consumption, we go for split function, that is predicted postoperative FEV1 and DLCO. If any one of them is less than 30%, peak VO2 is measured. If peak VO2 is less than 35%, pneumonectomy or lobectomy is usually not recommended and other options are considered. If it is more than 35%, calculated resection can be done. Preoperative airway management is essential for high-risk patients. Airway preparation, including drug therapy, combined with physical rehabilitation, it should be performed before surgery. The recommended physical rehabilitation measures include chest physiotherapy and incentive spirometry, climbing stairs, and power-based cycling. It helps to increase lung capacity and improve lung function. The intensity and duration of training are based totally patient-dependent. Preoperative anti-infective treatment with antibacterial antibiotics and prophylactic antibiotics help in reducing pulmonary complications. The goals of preoperative physiotherapy include maximizing lung function, improving respiratory muscle strength, enhancing secretion clearance, educating the patient on breathing exercises and coughing, and a major factor to reduce anxiety. Breathing exercises include deep breathing exercises, including incentive spirometry, diaphragmatic breathing, segmental expansion exercises, and for patient of COPD, pursed width breathing. The frequency is 10 to 15 breaths per hour. Airway clearance technique, also known as active cycle of breathing technique, ACBT. It is a training in which a patient is asked to control and give breaths, which helps in clearance of airways and also controlled breathing. Patient should also be given postural drainage and percussion if needed, and huffing and coughing training should be given. It minimizes sputum retention and helps to avoid atelectasis. Inspiratory muscle training, it is usually a device-guided training. It is done 15 to 30 minutes per day and should be started 2 to 4 weeks prior to surgery. It targets diaphragm and accessory muscle. It is usually indicated in patients with low FEV1 and who have high risk of post-operative pulmonary complications. Intraoperative management mainly focuses on positioning, monitoring oxygen, intraoperative recruitment maneuvers, and anesthesia is a main factor which helps during and after surgery to avoid postoperative complications. Effective sedation, analgesia, and muscle relaxation, rapid postoperative awakening and recovery, and target-oriented personalized volume management is best to avoid postoperative acute lung injury. Intraoperative application of bronchodilators, if required, may also be used to reduce bronchospasm. Thoracic surgery usually requires a double lumen endotracheal tube for one lung ventilation. It is used to ensure adequate surgical exposure while maintaining adequate oxygenation and to avoid acute lung injury. The lung protective ventilation strategies comprises of low tidal volume, that is 4 to 6 ml per kg, low PEEP, and lung recruitment. Low to moderate FiO2 of 30 to 50% if satisfactory oxygen saturation is made. Surgical management should be minimally invasive. If an open approach is opted, muscle-sparing thoracotomy should be used as an alternative to posterolateral thoracotomy. Excessive stretching, squeezing, and twisting of the lung tissue must be avoided. We need to follow two maximization, that is maximization of removal of the tumor and maximization of the preservation of lung tissue. Early postoperative physiotherapy goals include prevent respiratory complications, restoration of lung volumes, improve oxygenation, promote early mobilization, maintain functional independence. Multidisciplinary collaborative airway management strategies include incentive spirometry, coughing and deep breathing, oral healthcare, patient and patient family education, early and ambulation at least 3 times daily, and raising of the head by 30 degrees. It substantially reduces the incidence of pneumonia and re-intubation in postoperative period. Use of oxygen therapy to maintain SpO2 more than 92% with nasal cannula or mask as per need, and taper oxygen as patient improve. It is integrated with physiotherapy exercises. Rational use of analgesics is very useful because it promotes early diaphragmatic movement, helps to patient cough and expectorate without pain, thereby reducing damage to lung function and decreasing pulmonary infection. Pain can be alleviated by early removal of chest drain. On day 0, that is on the day of surgery, after proper anesthesia, patient should be kept in half-lying position with support, breathing exercises to expand all the remaining part of the lungs, vibration over unoperated side, huffing with incision support, segmental expansion exercises, and postural drainage by elevating the foot of the bed if required. On day 1, the patient should be kept in half-lying position. Foot and ankle exercises should be done. Quadriceps contraction, hip and knee bending and stretching, assisted arm movement on the operated side, breathing exercises with inspiratory holding, adding vibration on the operated side plus percussion as required. Side lying on the unoperated side with no obstruction in tails and upper arm supported by pillow and one more pillow under the leg. On day 2, similar to first day position, self-supported hopping, arm exercise with full range, trunk exercises, abdominal contraction. Patients should not be encouraged to sit cross-legged because of risk of DVT. At the end of second day, if all the other circumstances allow, chest drain should be out. The patient can go for a short walk. On day 3 and day 4, up to 2 to 3 22 sessions per day, the patient may be introduced to group therapy. Trunk and arm exercises continued. Walking distance should be increased. Self-care activity and stair climbing should be started. Subsequent treatment includes bilateral breathing exercises. Stitches may be taken out after 7 to 10 days, and the patient may be discharged between 10 to 12 days. Post-operative patient education includes home exercises, post-drainage, gradual return to activity, monitor warning signs like fever, increasing sputum production, dyspnea, advise smoke cessation and good nutrition advices, gradual walking or cycling, upper and lower limb strengthening, improve functional capacity, and start as per patient tolerance. This is totally individualized. The outcome of perioperative physiotherapy is reduction in postoperative pulmonary complications, shorter hospital stay, improved exercise tolerance, and better quality of life. This one journal article, Perioperative Physiotherapy in Patient Undergoing Lung Cancer Resection. This included randomized controlled trials that was published till 2013. It was a systemic reviews of the trials. It concluded that the pre-surgical intervention based on moderate intense aerobic exercises in patient undergoing lung resection for lung cancer improved functional capacity and reduced post-operative morbidity, whereas patients who went for post-operative physiotherapy do not seem to reduce post-operative pulmonary complication or length of hospital stay, but no firm conclusions could be drawn because of the heterogeneity of the studies included. It concluded that preoperative physiotherapy improved exercise capacity and helped in preserving pulmonary function following surgery. 9 references.
Thank you very much. So it was a very simple topic, but we must remember all this stuff. So only few things she mentioned very well. She said very typically that when we do the lobectomy, the patient should be turned in the other side, right? Not on the operator. So the operator side should be up, and the normal side should be down. If we are not giving the forwards position, so this is the one thing. There is one contraindication. Can you mention when we do not put on the opposite side? I mean, the operative side should be up, the non-operative side should be down if the patient is lying on the lateral side. So, can you mention any surgeries where we do just the opposite way? And why? While lobectomy garda जिसमें surgery the operative side the main axis, your non-operative side तल राख्छ lateral position राख्छ. तर कुनै conditions जसमा राख्दैन pneumonectomy. See, the patient has undergone pneumonectomy for 2 reasons. One, there is generally no drain to have pneumonectomy. So drain tube doesn't make it happen. And second, if you put on the same side, so the contralateral side, what happens by the gravity, the fluid should be coming down. It will come over the bronchial stem, and that will, in the early, the 0 postoperative, in the first postoperative, that will somehow hamper with the healing of the bronchial stem, and that may cause higher incidence of the fistula. It is not recommended for the pneumonectomy. So for the pneumonectomy, it's better to turn on the same side. The patient is not being very good. So you are a comparison to you. And whatever she has said is very relevant. Next, she has mentioned about the postural drainage. So sometimes what happens, our mentality is that we should keep the patient in the forward position, forward spread by actually broke the comfortable position. By both the by the side, it doesn't disturb the position of the patient. Sometimes what happens, let's suppose the patient has got the secretion over the lower limb. So if you have lower lobes of the lung or sixth segment of the right side, so if the patient is kept in the sitting position, that part of the lung will never be trained, right? So in that way, that point of view, you have to make the anti-gravity position. That's one exception when the posterior is required. Depending on where is the location of the secretions, retrolactatic part, secretions are there, so unblock that, you have to do posterior gyrus, this much position, CS must observe. Give the relevant finding, whatever, besides that, whatever she has answered. They all the malaxism say quite obvious. So physiotherapy is a very good thing. We have to educate the patient preoperatively. Quitting smoking is also very essential 1 month prior. So yeah, may have feasible room now. It's very available scan garage and support incentive experimentation. So breath holding is very good exercise. Either you do the incentive spirometry or simply the patient should be educated and you should hold the breath as much as possible. So 30 seconds he has mentioned. Some patient can hold more than 30 seconds, that's better. Do a simple bicycling exercise, jogging, etc. If not contraindicated, there are certain steps when the certain exercises may be contraindicated. Some patient has gone by the side, some eye surgery. So this coughing or huffing or whatever exercise may not be recommended, when the incentive is spirometry. So we should weigh benefits against the risks. So what is essential? The eye surgery was more important. We have to hold the lung surgery for next alternative time. You depend on the so what if some patient has got the emergency phlebotomy at the same time the patient has not recovered fully well from the myocardial infarction. So the excessive exercise may be contraindicated in those scenarios. So you could but our protocol should be, as you have seen our instruction, when the patient comes, we first thing, we extubate the patient on the table. It's in contrast to the other part of surgery. Neurosurgeons prefer to keep the patient ventilation. Other maybe GI surgeons, maybe complicated surgeries. When I was in DPK, their mentality when the Whipples was done, they think it's a very big operation. Patient should be kept ventilated for at least 24 hours. That was the thinking. Right? But now we think in thoracic surgery, the extubation on the table is the most important. Second, as early as possible, as you mentioned, the stress tube should be removed. So for that, intraoperatively, you should be very careful in handling the lungs. Staple all so that the ear leakage is not there. So if you remember, Dr. Shin was very meticulous. Even he used to suture all the subcutaneous where so that it appeared very good. It's not just for thing where hurry everything, doing everything, but that is the most meticulous. You spend extra 10 minutes of time. That will be 10 days earlier you can discharge the patient. So meticulous the handling of the lung tissue, switching each and every possible with the rear leakage there. Take an extra time, close the ear leakage so that you can remove in the posterior period earlier the chest tube. That is also very important to set. The questions he has mentioned very well and also the chest tube. What I think is in any lung resection surgery, in this patient, if you feel that the patient has got the secretions in the major bronchial tree, and patient cannot cough out despite the physiotherapy, we should do early bronchoscopy. Early bronchoscopy and suctioning of the secretions inside the bronchial tree. So this should be must in our kind of patients. But besides that's very wonderful talk. Very straightforward.
So preoperative, optimization like the preoperative physiotherapy, the school of that is probably
We test smoking one month before.
4 weeks before.
The physiotherapy breath holding in 70 days spirometry, which is great. COPD components are advice for the beta agonists. That's it. Simple cardiopulmonary exercise.
So in our setup, how can we make patients go through the physiotherapy like 2 weeks before surgery?
In our setup, maybe not always possible because the waiting time may not be too long and patient may not be willing to wait for 1 month or that period of time. So whatever the time is there, 2 weeks of time, for example, is there, just give me our QR code, scan it, गोटु गन्जाले सर कसरी बोल्नुहुन्छ उहाँले एक्सर्साइज कसरी गर्ने सक्यो यसको यो हुन्छ हाम्रो युट्युब हेर्नु उहाँ सरले बोल्नु भएको छ कसरी गर्ने एकदम राम्रो छ भन्नाले चाहिँ एजुकेसनल छ भिजिटरहरूलाई सिम्पल ल्याङ्ग्वेज नेपाली ल्याङ्ग्वेजमा भनिया छ सबैले बुझ्छन् राम्रो छ भने हाम्रो यहाँ चाहिँ त्यही गर्न सकिन्छ पहिला मैले रोटो क्यापिटललाई दिनु मिल्छ भने बिटा ओभलिस्टहरू जुन आवश्यक छ भने obstructive components.
Maybe we can even refer our patients to physiotherapy for preoperative physiotherapy.
Oh, that's
मेरो भान्जाले त्यस्तै
न्युट्रिसन डेभलप गर्न सकिन्छ न्युट्रिसन डेभलप गर्न इट इज कमिङ अफ प्रोटिन भनेर डाइट